Hello everyone, welcome to Easy Medicine. Today we have this 72-year-old male by name Mr. Ramesh. He was found to have incidental hypertension during a routine checkup with a blood pressure reading of 150 by 90 millimeters of mercury. You are a doctor there and you tell me when and how should you start the treatment in this patient. Now, another scenario is that the same patient presents to you with dizziness and vomitings. On examination, his blood pressure is 200 by 100 millimeters of mercury, and again you are available in the casualty. How would you like to manage this patient? At the end of this video, you will be able to clearly tell me how would you manage the patients. Now, let's get deep into this topic, the hypertension. So, we are going to discuss this topic in this brief outline, starting with the definition, staging, etiology, target organ damage, treatment. We'll discuss about the masked hypertension and white coat hypertension. How would you treat the hypertensive urgency and emergency? What are they? And some tidbits at last. So let's start with the clinical definition. The clinical definition says a systolic blood pressure of more than 130 millimeters of mercury and a diastolic blood pressure more than 80 millimeters of mercury in at least two seated blood pressure readings during at least two outpatient visits confirms the presence of hypertension. Now let's look at the staging of hypertension. This is according to the American College of Cardiology or American Heart Association, where the staging goes as follows according to the systolic blood pressure and the diastolic blood pressure. The normal is less than 120 and less than 80. And elevated hypertension is systolic less than 130 millimeters of mercury and diastolic again less than 80 millimeters of mercury. The stage 1 hypertension is systolic blood pressure less than 140 millimeters of mercury or the diastolic less than 90 millimeters of mercury. And lastly, stage 2 hypertension is systolic more than or equal to 140 millimeters of mercury or diastolic more than or equal to 90 millimeters of mercury. Right? This is the staging of hypertension. In addition to these stages, here only we can understand two different conditions, which are the hypertensive urgency and hypertensive emergency. Both of them are called as the severe hypertension or the hypertensive crisis. Both of them are differentiated with the presence of target organ damage. Hypertensive urgency means the systolic blood pressure is more than 180 millimeters of mercury or the diastolic blood pressure more than 120 millimeters of mercury, but there is no target organ damage. When you call it as hypertensive urgency, the systolic and diastolic will be more than 180 by 120, but there is target organ damage here. Okay, now let's look at the etiology of hypertension. The most common cause is primary hypertension or essential hypertension, which is of multifactorial origin, and the other one is the secondary causes. So we have a lot of secondary causes. The most common one are the renal ones. In the renal as well, the renal parenchymal disease is the most common one, followed by the polycystic kidney disease, renal tumors, obstructive uropathy, followed by certain renovascular diseases where the patient can have atherosclerosis in the renal arteries or fibromuscular dysplasia, which could again result in renal artery stenosis. All of these renal diseases will result in the hypertension in the patient. Under endocrine causes, we have acromegaly. Acromegaly is nothing but excessive production of growth hormone. The growth hormone is anti-natriuretic. It is not going to allow the sodium to pass into the urine, and hence there is sodium retention in the body that will result in hypertension. Then hyperthyroidism. The thyroxine function itself is to increase the cardiac contraction. Right. So when there is increased cardiac contraction, there is increased systolic blood pressure. Hence there is systolic hypertension in hyperthyroidism. Whereas in hypothyroidism, there is diastolic hypertension. What is the reason? Because the thyroxine is also responsible for the vasodilation. But when the thyroxine hormone in the body is less, the vessels tend to undergo vasoconstriction, and the vasoconstriction will result in diastolic blood pressure, or the vasoconstriction will result in increased peripheral resistance, and that will further result in increase in diastolic blood pressure. Now, hyperaldosteronism, we know that aldosterone is going to increase the sodium and water reabsorption, again will increase the fluid overload, and again hypertension. The Cushing syndrome is actually because of excessive production of cortisol, but the excessive production of cortisol will also have some mineralocorticoid action, and similarly, sodium and water retention will be the resultant effect. The pheochromocytoma is because of an adrenal tumor which is going to produce catecholamines, that is noradrenaline and adrenaline. Obviously, they are going to have significant effect on the blood pressure, and the blood pressure will be high. Hypercalcemia can also result in hypertension. Now we have certain neurogenic causes as well. One of them is raised ICT. When there is increased intracranial tension or intracranial pressure, our heart has to pump in more blood in order to increase the main arterial pressure so that the cerebral perfusion to the cerebral vessels and the brain is restored. So look at the formula. The cerebral perfusion pressure is equal to the mean arterial pressure minus the intracranial pressure or the intracranial tension. So for maintaining proper cerebral perfusion, there needs to be a high level of mean arterial pressure in order to overcome the high intracranial tension. Hope you understood this. And we also have this acute porphyria that can again result in hypertension. And last but not least, the obstructive sleep apnea. What is happening in the obstructive sleep apnea? This has become very common nowadays because of the increasing in the incidence of obesity. The obese patients will have snoring during the sleep, and they'll have episodes of apnea. Whenever there is apnea, there is increase in the sympathetic tone. This prolonged increase in the sympathetic tone for a long period of time will result in hypertension in these patients. Now let's see how the hypertension is going to affect different organ systems in our body. Let's start with the cardiovascular system. Now, the initiation of the essential hypertension could be because of the multifactorial causes, but the important ones are the increase in the RAS activity and increase in the sympathetic tone, because of which there is vasoconstriction, and the arteries are the vasoconstricted now, and also there is RAS activity will also result in sodium and water retention. There is volume overload inside the intravascular compartment, and there is also vasoconstriction. Both of them will result in hypertension. And because of this, the vasoconstriction, it is going to increase the peripheral resistance, and the pressure against which the heart has to pump the blood is also increased. So there is also immense pressure inside the systemic aorta that would result in aortic dissection and aortic aneurysm. Right, because of the intense pressure, the intima is going to break and blood will enter into the arterial wall, where it is going to split the tunica media and the tunica intima, and the blood gets filled in between these two layers. The other one is an aneurysm, where because of chronic pressures inside the aorta, the valves are going to become weak and they are going to bulge out, resulting in the formation of an aneurysm. The aortic valve can develop aortic regurgitation here. Because of the chronic increase in the afterload, LV undergoes concentric LVH because of consistent pressure that needs to be built up in the left ventricle. And left atrium will have the backup of blood because the concentric left ventricular hypertrophy will result in a reduced compliance of the ventricle that would result in heart failure with preserved ejection fraction, because of which the left atrium is dilated, the left atrial enlargement happens, and eventually atrial fibrillation. Further backflow of blood into the lungs will result in pulmonary edema, and all the symptoms are nothing but heart failure. Right, we have already discussed them. Now, when you look at the arteries, when there is endothelial dysfunction and vasoconstriction of the arteries, particularly the coronary vessels, the coronary atherosclerosis can result in myocardial infarction, because there is decreased supply because of coronary atherosclerosis, and there is also increased demand because of left ventricular hypertrophy. So this supply demand mismatch can increase the incidence of myocardial infarction in these patients. And disease of peripheral arteries can result in peripheral arterial disease, where the patient will limbs may undergo ischemic changes and gangrenous changes eventually. Now let's look at the other system-wise effects as well. The central mechanisms for the development of the target organ damage is endothelial dysfunction and atherosclerosis. That is one mechanism, and the other one is increased pressure and shear stress on the wall. Okay, so when you broadly look at two important mechanisms because of which all the target organ damages are happening, these two are the important ones. The one is endothelial dysfunction and atherosclerosis. The other one is increased pressure, the increased intraluminal pressure inside the blood vessels, and also the shear stress on the wall. Now we have already understood what would be the effect on cardiovascular system. The patient can develop myocardial infarction, left ventricular hypertrophy, and heart failure. And because of increased pressure, the patient may develop aortic dissection and aortic aneurysm. Now, the effect on the kidney. Increased shear pressure or shear stress on the wall can also result in AKI and CKD in renal disease. How? Let me explain. So, because of increased pressure inside the renal artery, there can also be increased pressure in the glomerulus. Our nephron doesn't want that. What will it do? It will reflexly vasoconstrict the afferent arteriole, that is the vessel that is coming or feeding the glomerulus. The afferent arteriolar vasoconstriction will result in the reduced GFR when it is prolonged, and this reduced GFR will result in acute kidney injury and chronic kidney disease. The effect on the central nervous system. Because of the atherosclerotic plaque formation, there is reduced blood flow to the brain, and sometimes sudden disruption of blood flow will result in transient ischemic attack, ischemic stroke, and vascular dementia because of multiple lacunar infarcts that may happen inside the cerebral vessels. And increased pressure may result in the rupture of the vessels inside the brain with the formation of microaneurysms prior to that, and that will result in hemorrhagic stroke. Sometimes the subarachnoid hemorrhage as well can happen. The effect on the retina. The patient can develop hypertensive retinopathy, and because of increased pressure, there can be retinal hemorrhages. And in regard to the peripheral circulation, the vasoconstriction will result in peripheral limb ischemia, that is, peripheral artery disease and gangrenous changes may happen. Then increased wall pressure may result in aneurysm and its rupture. So these are all the effects of the hypertension on different organs of the body, and together all of them are included under the simple heading, that is target organ damage. Now let's look at the evaluation of this patient. Do an ECG and echocardiography to look at the cardiac abnormalities that are apparent, and do renal function tests that are the creatinine, estimate EGFR, also do the electrolytes, complete urine examination, and urine albumin creatinine ratio. They are going to assess the kidney damage in this patient. Look at the fasting glucose or HbA1c level to screen for the sugars or diabetes, and do a fasting lipid profile to assess the cardiovascular risk, and do some additional tests if you are suspecting secondary hypertension. For ruling out primary aldosteronism, do a plasma aldosterone renin ratio. And for ruling out hyperthyroidism or hypothyroidism, do a thyroid stimulating hormone test. For ruling out pheochromocytoma, do a 24-hour urinary or plasma metanephrines. And you can also do a renal ultrasound for ruling out the renal artery stenosis in the patient of refractory hypertension. Now let's look at the treatment. The treatment includes lifestyle modification or the non-pharmacological treatment, and also the pharmacological treatment. The lifestyle management or the lifestyle modifications include weight reduction to BMI of 25 kg per meter square, and weight circumference should be reduced to less than 1 or 2 centimeters in men and less than 88 centimeters in women. When you talk about the diet, we should advise DASH diet, which is rich in fruits, vegetables, and low-fat dairy products, and also the foods which are rich in potassium, calcium, and magnesium, right? And the dietary salt should be restricted to less than 6 gram per day of sodium chloride. And when you talk about alcohol, alcohol should be reduced to less than 2 drinks per day in men and less than 1 drink per day in women. In regard to the physical activity, a regular aerobic physical activity or the brisk walking should be done for at least 30 minutes per day. And the lifestyle modifications are advised for all the patients of elevated blood pressure and any stage of hypertension. Irrespective of staging, each and every patient of elevated blood pressure should receive the advice for lifestyle modifications. And after this lifestyle modification, now we move on to the pharmacological treatment. What are you going to do? You are going to give antihypertensives, right? So let's see how to start the antihypertensives. So whenever a patient comes to you for the first time in an OPD and you have on examination found high blood pressure, measure both the arms. Okay, measure blood pressure in both the arms and take the one with higher blood pressure. Okay, note the reading, and if he has come for the first time, you can send the patient back to home and recheck at least 1 to 4 weeks later, at least 1 week later. So if you again find high blood pressure in the subsequent visit, rule out white coat hypertension. White coat hypertension means the patient may not be having hypertension at home, but as soon as he comes to the office or the hospital, the patient will show hypertension, right? So after the second reading, if the patient is persistently having high blood pressure, he is confirmed to have high blood pressure or elevated blood pressure. Now, depending upon the levels, if the blood pressure is still less than 130 by 80 but more than 120, it is elevated hypertension. And if the blood pressure is less than 140 by 90, it is stage 1 hypertension. When the blood pressure is more than 140/90, it is stage 2 hypertension. If the patient is having only elevated blood pressure, advise lifestyle modifications. Do not go for the pharmacological treatment. If the patient is having stage 1 hypertension, assess the cardiovascular disease risk. If the patient is having no cardiovascular disease risk, then advise lifestyle modifications and just keep on monitoring the patient. Do not advise any pharmacological treatment. If the patient is also having a 10% risk of atherosclerotic cardiovascular disease risk, then advise lifestyle modification and also start the drugs. If the patient is stage 2 hypertension, irrespective of the atherosclerotic cardiovascular disease risk, start the patient on pharmacological management as well, along with the lifestyle modifications. So whatever the stage the patient is in, the target blood pressure will be to reach 130/80 millimeters of mercury. Hope you understood this entire flowchart. This would help you in identifying the patients whom to treat. Let's see what to start for the patient. For any patient, start with the combination of two first line drugs. We have first line drugs as well as the second line drugs. The first line drugs are A, C, and D. A for AC inhibitors or ARBs, C for calcium channel blockers, and D for diuretic, that is a thiazide diuretic. And the second line drugs are beta blockers, alpha blockers, nitrates, central sympatholytics, loop diuretics, mineralocorticoid receptor antagonists, hydralazine. All the other antihypertensives are included under the second line drugs except for A, C, and D. Right? Now, if the blood pressure is more than 140/90 millimeters of mercury, despite using all the three first line drugs, including a diuretic, you call it as resistant hypertension. Right? If the patient has resistant hypertension, then you can start with the second line drugs. If the patient is a diabetic, you would like to start AC inhibitors or ARBs. If the patient is a CKD, again start AC inhibitors or ARBs. The reason here is that the diabetic kidney disease will eventually turn up in the patient if the patient is a long-standing disease of diabetes. That is why the AC inhibitors or ARBs should be used. They are going to reduce the incidence of proteinuria and they are going to prevent the incidence of diabetic kidney disease for some time. If the patient is a known case of coronary artery disease, start with AC inhibitor or ARB and a beta blocker. Why? Both of them are having certain mortality benefit in these patients and they are going to reduce the cardiac remodeling also in these patients. If the patient is again having heart failure, the three first line drugs are mineralocorticoid receptor blockers, beta blockers, and AC inhibitors are ARBs. Along with that, we have SGLT2 inhibitors as well. Together, all these four include under the first line drugs for the management of heart failure. Now, what are the drugs that have to be preferred and avoided in pregnancy? In pregnancy, the drugs that are advised are nifedipine, labetalol, hydralazine, alpha methyl dopa, and the drugs that should be avoided are diuretics and AC inhibitors or ARBs. ARB stands for angiotensin receptor blockers. So let's differentiate the masked hypertension and the white coat hypertension. So based upon the office blood pressure, home blood pressure, and the end organ damage. The masked hypertension, the office blood pressure will be normal. That is why it is called as masked. Where if you look at the ambulatory blood pressure monitoring, which is done at home, or the home blood pressure monitoring, the blood pressure is elevated and the end organ damage is usually present in these patients. In a patient of white coat hypertension, when the patient comes to you to the clinic, the blood pressure may be high, but it is usually normal at his home, and end organ damage is less likely in these patients. How would you differentiate between them? You can do an ambulatory blood pressure monitoring or home blood pressure monitoring, where a blood pressure monitor has been set up to the body 24 hours a day, and thereby the changes in the blood pressure are recorded in the monitor. Now let's look at the management of severe hypertension or the hypertensive crisis. So when the blood pressure is more than 180/120 millimeters of mercury, you can call it as severe hypertension or the hypertensive crisis. We have two different kinds of crisis. That is hypertensive urgency and hypertensive emergency. When there is target organ damage, you call it as hypertensive emergency. When there is no target organ damage, you call it as hypertensive urgency. So when the patient is having hypertensive urgency, directly admit the patient to ICU because there is target organ damage. Start intravenous antihypertensive drugs lower the blood pressure gradually in the first few hours unless the patient is having an acute ischemic stroke or aortic dissection. The management in these cases is different. We'll be subsequently looking at them. If the patient is having hypertensive urgency, that is without any target organ damage, you can give oral drugs instead of intravenous drugs, and you can discharge the patient as soon as the symptoms have improved and when the blood pressure falls to less than 180 by 110 millimeters of mercury. Of course, you should continue the oral management even while the patient is at home. The management of hypertensive urgency requires the usage of oral drugs like captopril, labetalol, nicardipine. You can also use clonidine for that matter. For the management of hypertensive emergency, intravenous drugs like nicardipine, nitroglycerin, sodium nitroprusside, labetalol, esmolol should be used. Our primary goal in most of the hypertensive emergencies is to reduce the systolic blood pressure or the mean arterial blood pressure by less than 20 to 25% in the first hour. Okay, don't reduce more than 25% in the first hour. And the goal of 160 by 110 millimeters of mercury should be reached by next 2 to 6 hours. And eventually bring the blood pressure to normal over the next 24 to 48 hours. This is the usual advice that will be given for generally any case of hypertensive emergency, but let's look at the exceptions. When the patient is having acute aortic dissection, we have looked at the image, the intima and the media are splitting away from each other because of the flow of blood in between, and it can be resulting in a mortality of the patient. So, immediately bring the blood pressure back to 120 millimeters of mercury within the first hour and bring the heart rate to less than 60 beats per minute. This requires control of blood pressure as well as heart rate. That is why you need an intravenous beta blocker, that is an IV esmolol or IV labetalol. And you can also use vasodilator, that is nicardipine and nitroprusside in intravenous formulation. If the patient is having an acute ischemic stroke, so when the patient is having ischemic stroke, there is some cerebral vasoconstriction or the cerebral vascular occlusion. You need to maintain the cerebral perfusion pressure. Because of this reason, do not control the blood pressure rapidly, because when you control the blood pressure rapidly, cerebral perfusion pressure also falls down. That is why there are a couple of permissible limits. When the patient is undergoing thrombolysis, the permissible blood pressure is 185 by 110 millimeters of mercury. If the patient is not undergoing thrombolysis, the permissible blood pressure is 220 by 120 millimeters of mercury. If the patient is having preeclampsia or eclampsia, again you need to immediately bring back blood pressure to less than 140 millimeters of mercury. So reduce the systolic blood pressure to less than 140 millimeters of mercury within the first hour. And the drugs that have to be used are labetalol, hydralazine, nicardipine, nifedipine, alpha-methyl-dopa. All these drugs which we have already discussed in the management of a pregnant female. In case of hemorrhagic stroke, immediately reduce the blood pressure to less than 140 millimeters of mercury. Why? Because the whole bleeding that has happened inside the brain is because of the increased intraluminal pressure or the increased blood pressure in the cerebral vessels. If the blood pressure is still high, there is continuation of the hemorrhage that is happening inside the brain, and that would eventually result in the midline shift, and the patient may eventually land up in the uncal herniation and the patient may die immediately. So, immediately reduce the blood pressure to less than 140 millimeters of mercury. There are certain precautions that have to be taken while managing a few types of hypertensive emergencies. One such one is pheochromocytoma. Avoid beta blocker alone in sympathetic crisis or pheochromocytoma. Avoid nitroprusside in acute kidney injury because of risk of cyanide toxicity. Avoid nitroprusside in posterior reversible encephalopathy and the hypertensive encephalopathy because the nitroprusside can increase the intracranial pressure in these patients. Hope you understood the entire lecture of hypertension. I'm sure that you will be able to treat our patients, which I have mentioned in the first. Answer in the comments how would you like to treat those two patients, and if you have found value in this video, please share with your friends, subscribe this channel and hit the bell icon. Thank you. We'll meet you in the next video.